My name is Aria Fallah, and I will be discussing our paper recently published in the journal Neurosurgery. It's entitled Preliminary Experience Suggests the addition of choroid plexus cauterization to functional hemispherectomy may reduce post-hemispherectomy hydrocephalus. Clinical context. So despite the efficacy of cerebral hemispherectomy for treating diffuse hemispheric intractable epilepsy, post-hemispherectomy hydrocephalus is prevalent, affecting about 25% of patients. This is associated with reduction of quality of life, increased morbidity, and in rare cases, mortality. Approximately 85% of children with shunted hydrocephalus experience CSF shunt failure and have an average of about 3 revisions. In a recent meeting in 2019 to identify knowledge gaps following pediatric epilepsy surgery, hydrocephalus research was identified as the top priority. So developing techniques that prevent post-hemispherectomy hydrocephalus is essential for maximizing quality of life in children undergoing hemispheric surgery. Question of our study: the primary objective was to determine the effectiveness of choroid plexus cauterization in preventing post-hemispherectomy hydrocephalus. We also wanted to determine if it's safe by evaluating seizure of freedom as well as complication rates. We hypothesized that including CPC decreases the incidence of post-hemispherectomy hydrocephalus without compromising the effectiveness or safety of hemispheric surgery. This was a retrospective observational study performed at a single academic quaternary referral center for pediatric epilepsy surgery. It was done using electronic medical record review. So from February 2016 to February 2021, CPC was routinely performed in patients undergoing functional hemispherectomy surgery whenever possible. This cohort of patients who were treated with and without CPC was compared to an equal number of consecutive patients immediately prior to February of 2016. We used multivariate logistical regression to identify factors independently associated with post-hemispherectomy hydrocephalus requiring CSF shunting. 68 patients were included in the study, of which about 38% of them underwent CPC. You can see that the rate of post-hemispherectomy hydrocephalus was 29% in the group that didn't receive a CPC, and about 8% in the group that did receive choroid plexus cauterization. We also had no patients who developed hydrocephalus following a de novo hemispherectomy with CPC. We compared the amount of CSF drainage from the EVD, and the CPC group drained almost half the amount as the group that did not receive a CPC. Both cohorts experienced similar seizure freedom and similar postoperative complications. Patients without CPC had an 8.4 greater odds of developing post-hemispherectomy hydrocephalus. So this suggests a number needed to treat with CPC to prevent an additional case of post-hemispherectomy hydrocephalus at 4.8. This is the first study to show prevention of post-hemispherectomy hydrocephalus through prophylactic CPC incorporated routinely into hemispheric surgery. Considering an NNT with CPC is 4.8, routine incorporation of CPC may be an effective strategy for preventing post-hemispherectomy hydrocephalus. The significant decrease in CSF production shown to be independently associated with CPC. It allows for insight into the mechanism of action. Limitations of our study include the retrospective nature of the study, differences in the length of follow-up between the cohorts, and the non-standardized decision-making for CSF shunt placement for post-hemispherectomy hydrocephalus. So in closing, incorporating CPC into hemispherectomy significantly reduces the odds of hydrocephalus, most likely secondary to decreased CSF production. There were no differences in complications or rates of seizure freedom, and prophylactic CPC is a promising adjunct surgical procedure to conventional hemispherectomy, but further multi-institutional prospective studies are required. Thank you.